And late morning to some of you. This is Dana at the NCSD office. I am the Technical Assistance and Health Equity Promotion Team lead here. And this is really exciting for us here at NCSD because we are debuting a series of conference calls called It's Your Call. And this is a series that we hope, and we designed it to really be a venue for all of our members to discuss topics that are pertinent to your jobs, things that you're interested in. And it's really an opportunity to share ideas with our colleagues and also an opportunity for you all to inform NCSD staff about what's happening on the ground. So we're really looking forward to these calls. If you are interested in a topic or being a lead discussant on a call in the future, please feel free to send me an email because we are interested in gathering all kinds of information so that we can have a good series of calls throughout the year, 6 to 8 or what have you, depending on member interest. And one of the things that I always say when I'm doing training and stuff is that I really think our colleagues are our richest resource. So hopefully these calls will be sort of a testament to that, and we're going to start them off with a great interest because we have a lot of people on the phone and a lot of people that were interested in this topic. Just so you know, the call is being recorded, so we ask that you please mute your phones if you aren't speaking. And also, if you are going to speak, we want you to please identify yourself. Unless, of course, you're running from the law, and in that case, you don't have to identify yourself. But if you're not, please identify yourself before speaking. Today's call is the rise in syphilis, unexpected places and persons. As you all know, we've talked about it at the annual meetings and things. There has been a rise in syphilis in pockets throughout the country and in specific populations. So we definitely thought it would be interesting to have our debut call for something that is going on that's a hot pocket that's trending right now. The lead discussant for today's call is Jan Fox. Jan is a registered nurse with a Master's of Public Health and Epidemiology. She is the STD HIV Chief in Oklahoma. Following the talk with Jan, we hope to have some discussion about syphilis morbidity in your jurisdictions. Of course, ask Jan any questions that we might have from her presentation, and also talk about what prevention and intervention tools that folks are using throughout the country. So let me just say a little bit more about Jan. She is, as I said, the HIV Std Chief in Oklahoma. She has a Master's of Public Health and Epidemiology, and she's worked for Oklahoma State Department of Health for the past 24 years. First as a public health nurse, then later as a Hep C coordinator, and then followed by Director of Care Delivery. For the past 3 years, she's been the HIV Std Chief. And in this capacity, she oversees all Oklahoma public health programs related to STDs, HIV, and viral hepatitis. We're really happy that Jan wanted to be our first discussant here, and there are a lot of good things that are going on in Oklahoma. I'm sorry. There are a lot of good things that are going on in Oklahoma, and we're really excited. And we're really happy that Jan is up and in good health and moving around and feeling good because she recently donated a kidney to her husband, and he's doing very well as well. So we're really happy that you're doing well, Jan, and your husband's doing fabulous, and we're excited about your presentation and the discussion that will follow.
Okay, well, thank you so much, Dana, and hello, everyone. I did return to work last week, and I am up and running and feeling really good, so I appreciate all those kind words and thoughts. Today, I will be presenting information about a rise in syphilis that has occurred in this past year in our largest, most populated county, which is Oklahoma County. But more importantly, I'd like to highlight the activities that we have undertaken to address the rise in Oklahoma County. I do want to introduce my colleagues who are here with me because they were the persons who were instrumental in investigating the cases. They're still investigating cases, and they were the reason that the campaign was so successful because they made it happen. And so I want to introduce Sally Baus-Pitzer, Kristen Eberly, and then calling in from Tulsa is Casey Price, all very important. And I know that if anyone has questions that I can't answer, I feel comfortable that they will be able to. We are a state that really does have limited resources, and so we always, or at least often, find it necessary to utilize any existing partnerships or utilize existing materials and resources, but we just have to use them in different ways and innovative ways. And so that's really the information that I'd like to talk about more than anything today. Basically, from January 1st, 2012 through March 7th, 2012, a nearly twofold increase of primary, secondary, and early latent syphilis cases occurred in the Oklahoma City area. These early syphilis infections involved mainly men who have sex with men who had been diagnosed with secondary syphilis infection. Between January and March, 16 Oklahoma City residents had been diagnosed with early syphilis, and one Southwest Oklahoma resident who happens to hang out at an Oklahoma City bar was also diagnosed. Of the 17 early syphilis cases identified, 14, or 82%, were self-identified as MSM. Nearly half were co-infected with HIV, that was 43%. Over half, 57%, had used the internet to find partners, and 50% had found partners at a particular Oklahoma City bar that is located in what is known as the gay district of Oklahoma City. On March 8, we declared that there was an outbreak among MSM in the Oklahoma City area. The following outbreak case criteria were established. To be considered a case, you had to be MSM, you had to be a resident of Oklahoma County or be connected with an Oklahoma County MSM bar, and have early syphilis or a titer of 1 to 32 or higher, or be connected to an early syphilis case. Our outbreak response protocol was initiated on March 8, 2012. For the Oklahoma City area, one DIS was designated to work only HIV cases, and that allowed the remaining DIS to focus on finding undiagnosed syphilis cases. We wanted to prioritize that, ensure that we were finding them. The staff worked to contact the sexual partners of active syphilis cases to inform them of the exposure and offer testing and treatment if needed. We also used our field surveillance staff to alert and educate providers all across Oklahoma of the rise of syphilis cases that were being identified. We printed and distributed the physician doc pocket syphilis guides. We presented them to the physicians and were successful in getting commitments from many of the infectious disease doctors to perform routine syphilis tests on their HIV clients. Several cases were identified using this new procedure, and we think that that was very beneficial. We also issued a HON alert, which is our fax alert that is just blast faxed to anyone who has signed up, and mainly includes physicians and different providers across the state. We activated this to alert primary care physicians, infectious disease doctors, hospital emergency rooms, and then all the local and state health officials in Oklahoma County and all the surrounding counties of the outbreak. And we included disease and treatment information in that fax. The Oklahoma State Department of Health, or what I'll refer to as OSDH, collaborated with the Oklahoma City County Health Department STD Clinic to ensure prompt service for the DIS referred clients, and to ensure that a TPPA was performed on all clients regardless of the results of the STAT RPR. In fact, 3 cases with negative RPRs and positive TPPAs were identified. Our field operations manager, who's Casey Price, who's calling in from Tulsa, throughout continuously evaluated case progression and connections. Other risks and barriers were identified, such as meth use and anonymous sex. Our field operations, surveillance, and health education staff continue to collaborate to provide partner services, data analysis, education, and outreach to create a seamless outbreak response. We also coordinated with our community-based organizations, or our CBOs, to begin syphilis testing along with the existing HIV testing for MSM clients. And the CBOs that began to offer syphilis testing were able to identify 3 new syphilis cases. Finally, we determined that there was a need to conduct a public awareness campaign. And so in order to do so, we took the following steps. The first thing we did was to explore existing syphilis campaigns that are out there. And then we pulled together a group of employees from our CBOs and other community members that were located in the target area and presented the campaign materials that we found that we thought might be useful. We asked them for their opinions. We had them rate them according to their perceived effectiveness. And finally, we selected the Syphilis Rising campaign that was developed by Public Health Seattle and King County. The campaign and the posters that they had developed are very appealing. I wish that you all could see them. It's very hard to describe what they look like, but they will capture attention. And basically what they are is the posters have a nice-looking male who has a rainbow on his chest, and he's holding up a bright red sucker to his lips, and the caption says, "Syphilis sucks, and not in a pleasurable way. And it's spreading. You can get it from oral or anal sex, so get tested today. Syphilis, easy to get, easy to cure, dial 211. So we approached the developers of the materials and were able to get their permissions to adapt them to our needs in Oklahoma, and they were more than happy to let us do that. And then we were able to get permissions through our local channels to embark on the campaign. We then met with our internal communications staff to put it all into place, collected ideas, and make plans for moving forward with the syphilis campaign. Luckily and coincidentally, really, earlier in the year we had taken state dollars and put it into a media contract. And because we didn't really have specific plans, but we know that every year we end up having needs or wishing that we had the ability to quickly do something with the media, and so we already had that resource in place and were able to use it for this project, and that went very smoothly, and we were able to do that quickly. We then met with the club owner, the one club that had been named over and over by the persons who were infected. We met with the club owner and manager, talked about the syphilis outbreak, and requested permission to conduct the campaign in the complex where that particular bar is located. And they were very happy and willing to work with us. And so then we met with other club owners and managers in the area about the outbreak, and were able to obtain permission to distribute the campaign materials in all the bars in that area. We then partnered with the Oklahoma AIDS Care Fund and were able to obtain additional campaign materials that we probably could have never coordinated on our own. This helped us to purchase the materials to put into condom packets, condom baskets, wall dispensers. We printed Syphilis Sucks t-shirts, and we purchased suckers, what are those called? Tootsie Pops. And attached a little tag that said Syphilis Sucks on one side and dial 211 on the other side. We also were able to get a QR code that was put on all of the posters, the small business cards. We put together some 4x6 cards. The QR codes would take anyone who scanned them directly to our website, to our syphilis page. And so that was kind of exciting. And then finally, one of the facilities donated a speaker dock to use as a prize for a random client who tested and returned for results. So our idea was that we would set up an outreach campaign at the bar and the bars in the area, and that we would set up for testing. Our purpose wasn't necessarily to test. Our purpose was to make people aware and to educate, but we did want to offer the testing. And so then we presented the campaign to the Oklahoma HIV Planning Committee and solicited volunteers, and we did get some very eager volunteers willing to help. So 2 weeks before the kickoff of the campaign, we put out some preliminary materials such as the posters and things we hung in the bars. And then we paid further visits to all the bars, to the bartenders, to the managers, to the employees of the bars to talk with them about the syphilis outbreak and to provide additional information. Then we had to organize the activities of the outreach workers. So we had to put together schedules. We had to educate all the volunteers about the campaign messages. And it ended up, if I remember right, that we had, our volunteers consisted of health department staff and volunteers from the Red Rock Behavioral Health Center. The day before the testing outreach campaign, we hung Syphilis Sucks posters in the bars, and we gave out outreach testing cards to all of the bartenders. The testing event occurred on, or the outreach occurred on May 3rd, where we handed out suckers, business-size cards, our 4x6 cards with the campaign messages on them. Outreach workers canvassed the area and bars talking with people about syphilis and the outbreak, where they could go to be tested. They handed out condom packets and other campaign materials, and just had a really great time and got a lot of good information out and were very well received. Testing was available and further outreach on May 4th, which was Friday, and May 5th, which was Saturday. And so the same materials were distributed then, but also there were announcements about the testing by the DJs on that day, on those 2 days. We then placed a full-page ad in the Gailey, Oklahoma newspaper in May and June. And then we had online ads on websites that were placed during the last 2 weeks of April, all of May and June. And we do know that the ads were picked up by at least two websites without any solicitation. So altogether, we think it was very successful. We had distributed 5,000 condom packets, 500 mini posters, over 300 syphilis campaign full-size posters, and 400 Get Tested Tonight cards. We did do 24 syphilis tests and 7 rapid HIV tests. We did not have any new positive as a result of the testing. Currently, we are still having a lot of cases. We have 46 cases that have been identified to fit the outbreak criteria. Of the 46, 44 have been interviewed by a DIS. The majority of cases, or 66%, have been identified through partner services or through a client presenting to the STD clinic with symptoms. Overall, 28 cases are included in 5 different clusters, and 18 cases have not been connected to another positive case. The DIS have done some really good work. They've initiated 199 contacts, generating a 4.5 contact index. Of the 199 contacts, 55 have been preventatively treated within the incubation period. DIS are still currently investigating 12 of the involved cases. And in conclusion, what we believe is that there's an increase of early syphilis cases that's basically a trend in Oklahoma County that's following the national trend of syphilis in the MSM population. Due to barriers of anonymous partners and using the internet to find sex partners, traditional outbreak response plans are just not as effective. And so to overcome this barrier, we are continuing to build our internet partner services, which we have been working on for quite a while and are beginning to provide. Traditional partner services by the DIS will continue to be offered. And additionally, we have used the opportunity to request from our agency's senior leadership to hire 2 additional DIS staff because we have had outbreaks in the past, and this is good rationale for why we need the staff, and so we're going to go ahead and ask for that. So that's basically my presentation. I'd be glad to take any questions if there are any.
Well, Jan, first let me just say thank you because that was really a great overview, and I just want to get some clarification. Did you say you initially you have 2 DIS?
No, for the Oklahoma City area, I believe we have 6.
Okay,
DIS.
But
what we did was we said, okay, one of those DIS is going to only work HIV cases, and then the others are going to focus on syphilis until we understand what's going on.
Wow, that's fabulous, and they're doing it great because if I heard you correctly, then that means they're interviewing about 96% of the cases that came through.
That's exactly right. They have really pulled up their bootstraps and been really busy.
Great. Thank you. Okay. Open it up. Questions for Jan, anyone?
Hi, Jan. This is Juan in Portland, Oregon. You mentioned 211 info a couple times. Could you talk about the relationship with 211?
Sure. We would be glad to. I didn't even think to say that's an Oklahoma-specific number that has been developed. It's a number, something like 911, except that if you call it, regardless of what your health needs are, you can be referred to whatever state or other agency can help you meet your needs. And so if you call 211, you can get information about HIV, STDs, where to go for testing, how to get treatment, and those types of things. And I'm going to ask Sally if she has anything to add to that.
It's just kind of like Jan said, like 911 is for emergencies, 411 is for phone number information, 211 is for social service and health information, and it's set up through the state of Oklahoma.
Right.
Other questions for Jan?
Janet Arno from Indianapolis. What is your rate? Have you seen any decrease in your rate of cases appearing? So,
do you mean specific to Oklahoma County?
Yes. So, for example, before were you seeing 8 a week, and now you're seeing 5 a week?
Okay, I'm going to ask Casey. Casey, are you there?
I am.
Can you answer her question?
I don't know that I can answer it accurately because I don't have the numbers. And with us going to 5.0, we haven't been able to keep up current, I think, with those numbers and just been able to look specifically at what we have going now, other than seeing that from January to July of last year with the same population, our cases doubled. But I hate to answer anything specifically about the rate because I don't actually have the information in front of me.
Well, I would like to say that we are in our 4th year of an outbreak which began among MSM, and there were several things that evolved over that time, which I think you can probably expect. One is we saw an abrupt decrease the first 12 months, where we were really fighting what appeared to be a point outbreak that occurred at an MSM bar where we had very high HIV-positive rates. And it was fantastic what you've done with your infectious disease physicians, and we had done something similar that really found a lot of cases, and we have them screen every 3 months still. What we saw evolve was a movement into HIV-negative populations and the evolution of a racial health disparity, despite our every effort to prevent that. While there was a predominance of white MSM in the beginning, although still proportionately black men were probably affected slightly more. The actual numbers, whites were predominant, and now we're seeing them moving ahead of African American men. And part of that is where people meet partners. It's relatively easy to find people who are at bars and bathhouses, but many more of our population now meet at friends' houses. Not just meeting on the internet, but it's much harder to do that kind of screening. So I have to praise your DIS sounds fantastic. Those are really great rates, and the more you can keep it from moving into that houses and friends, acquaintances, small exchanges, the better.
Thank you a lot for telling us your experience there, and it helps to reinforce that we've been headed down the right path, but that we may have a lot more coming.
And I do know that in 2011, we did see a slight decrease of cases, just looking at the January through July, comparing it to what we've had this year. From 09 to 10, it rose a little bit, and then in 2011, it probably dropped about 10%. and then it doubled in 2012.
And Jan, this is Dana again. It sounded like you had little or no resistance from club owners, and I just want to hear a little bit more about the approach. How did you approach them in it?
Sure. You're right. They were very willing to participate and just basically let us come and do what we needed and wanted to do. But I'm going to have Sally, a lot of that was because Sally, who's here, had really good relationships with the owners and the people who ran businesses in the area, and so I'll let her talk just a little bit about that.
I was really lucky because one of our former CPG members happens to be a manager of a couple of the clubs that we really needed to work with, so he was able to talk to the owner and introduce me, and then just networking and that kind of stuff. And once that I talked to one club owner, the Oklahoma City gay area, most of our clubs are all on one street or within a 2-block radius, so everybody knows each other. When the club owners, when they promote different things, they get together and they know each other, and so the particular main club owner got together and talked to a couple different club owners, so they knew what was going on, and then I was able to go and talk to them, and they had heard about things from the meeting with the other guy, and were just very receptive.
You know, we're lucky, I think, because in a way we have we're something of a small town. I mean, it's our largest city, and yet it's somewhat small, and most people, we know each other, and it's also helpful to have people who've worked in the field for many, many, many years and have worked with each other and have maintained good relationships throughout the years. That's been very helpful.
And then what also helped is that there's a large condom distribution campaign that goes on within the clubs, and it's done by several organizations that work together, so they've seen a lot of the different outreach workers out there, and the health department participates in that collaborative that was put together by the Oklahoma AIDS Care Fund, and so they see us out there every Friday making sure all the clubs have condoms and that kind of thing. So the clubs in general are very receptive to our messages and to our condom campaign, so that really helps get the syphilis information in the door.
Hey Jan, this is Rich in Illinois. I have a question about your Internet partner notification. Could you talk a little bit about how successful you are with notifying partners and getting them in for testing and possible treatment, and if you've had any issues with your upper management gaining access to some of these sex sites?
I'm very glad you asked that question. We have we've been working towards this for several years and really have made a lot of headway in the past year. So we're kind of up and running, and we're learning as we go. We are also lucky that our senior leadership really understands how much we need Internet partner services and is very supportive. The problem that we did have were some outside of our agency, some specific issues that prevented us from accessing specific sites. But we're working through all that, and we have permission. I'm going to have Kristen talk a little bit more specific, though.
Yeah, we're really new. We've been developing our policies for over a year now, but I think we just did our first notification maybe 2 or 3 months ago. So I think we've done to date 3 Internet partner notifications, and we had 2 not respond at all. We could tell that they received the notice, and 1 actually called and got information, but we're not aware if they went into clinic or not.
I have another question. This is Rich again in Illinois. I'm kind of struggling with what to do with this situation, and I don't know if other states have tackled this. But what we've been seeing here in Illinois, particularly in the Chicagoland area, and they're a separately funded project area, so that's some issues that I have with able to do things in that area. usually what we're seeing is some MSM that have been infected with HIV for 15, 20 years, but have been having syphilis infections about 4 or 5 times, just repeated syphilis infections. And obviously they're having unprotected sex and they're not getting the message. And I'm kind of struggling on how to handle that situation. I don't know if other states do any intense counseling with those patients, if you use your non-compliant carrier law to kind of scare them. But I was wondering if anybody has any experience with dealing with that situation.
Hi, this is
Go ahead.
This is Jessica in California. We definitely have in some of our counties high rates of reinfection with our cases, and specifically in San Diego County, sort of the approach that they started to take was kind of a test and treat model, getting people to test more frequently, and they developed a program called We All Test that does text or email reminders to get tested. So instead of focusing so much on trying to change behaviors, the focus went more toward getting people tested more frequently to try to reduce sort of transmission within the community. Because the behavioral change is really, really hard in such a high risk population that's getting infected multiple times.
This is Jan. We have a similar problem, and it's been very difficult for us to address also. We do have the ability to, use our Board of Health to issue compliance orders and things like that, but they don't seem to be terribly effective, and it's not really the way we want to go. So we have been trying to garner some support from our senior leadership to help us in other ways, maybe to put some state dollars into getting people into care and focusing on care for these individuals and hiring more DIS and those types of things. We're really trying to make the argument that that's a better way to go than to go down any legal paths.
This is Bernard from South Carolina. We also have similar tools we use. We actually have a recalcitrant policy that the state of South Carolina, the Department of Health has, that requires an individual who, and many of these individuals, we actually have a class for them called HIV 901s. These are previously positive people who are continuing to put others at risk and or, having children and that kind of stuff. When a person is identified by the DIS or reported as having another STD after a HIV positive diagnosis, the DIS gets involved, does the part of services part to identify individuals, but then they also link to a social worker who tries to engage that person, and if they're not in care, get them in care to reduce viral load and reduce their contagious or infectiousness and reduce transmission rates. Also, really, social worker really tries to work with the individual. And some of them we're not able to, but they try to work with the individual to see what the main issues are that are driving them to put others at risk. Some of them do it because they're in the sex industry, or that's how they pay their rent, or that's how they get their drugs or whatever. A few people we've gotten to alcohol and drug. We've gotten into both rehab. A few people we've gotten into care where they're on medications, their viral loads decreased and stuff like that. So it's kind of a individual, person-by-person approach we use with persons that we identify as continuing to put others at risk. And some people are just angry because nobody told them and they're going to do what they're going to do. We've applied the law in a roundabout way to a few people in isolation orders, but South Carolina isolation can only be up to 90 days and the person has to be released. And we don't like to use that because the public sometimes sees that as a deterrent to even get tested, because then they know that we know. They know their status. So then if something goes wrong, then they don't want the law to come after them.
Well, I like the model, hooking them up with the social worker. That's great.
who else out is seeing morbidity changes, and if so, what populations are they? Is it kind of specific to MSM community, or are there other populations that you're seeing morbidity changes as it relates to syphilis or HIV?
This is Amanda from South Dakota, and starting in April of this year, we were seeing definite morbidity changes in syphilis, early syphilis for us, and that's unusual for a small state to see syphilis. We've had 12 cases diagnosed in the last few months, 8 of which have been early syphilis. So our population is MSM, and a significant number that are HIV co-infected and that have had previous syphilis positives and are now reinfected. And we are seeing it in the adult bookstores, theaters, the glory holes, and with home parties. So it's a unique
particular race?
All white right now, and ages ranges from, our youngest was 23 up to 63. So we are seeing internet hookups, anonymous partners, and a lot of Craigslist, and I'm unsure of how to do any internet partner services with Craigslist, so I would take any suggestions in that area.
I mean, in Illinois, we contract with Howard Brown Health Center, which is the largest provider of gay health care to gay, lesbian, bisexual, transgendered questioning people. And they actually do a lot of internet partner notification for us. An example, in Central Illinois, one of the health departments identified a young man with syphilis, and he had like 48 sexual contacts. Health department staff gathered the profile names. We faxed them to Howard Brown. They did outreach on the internet, and they got 20 people to go into the health department to be tested and preventatively treated. They're a long-standing professional organization that provides medical care, so that's been a good partner for us, because we've had issues of getting access to the internet and to those sites here.
Yeah, we're doing Facebook and Manhunt, and it's working okay, but a lot of the men are saying Craigslist, or they're just hooking up at the bookstores, or aren't wanting to give partner names, which I guess
now you have Grindr and Mister also out there.
Yeah, and getting executive management to approve that those things are going on in our state has been hard.
This is Amy from Louisiana. I have a quick question. Who was it that Illinois said they were partnering with to do the internet partner notification?
It's Howard Brown Health Center.
Okay, thank you.
This is Jessica. I have a recommendation for the Craigslist issue, which is that oftentimes the email address is anonymous when you send the initial email to respond to the person on Craigslist, but then when they respond to you, it's often not anonymous, so you may be able to go through your email, or the cases go through their emails and find that the email address and use that to contact the partner.
Thank you very much.
I actually have a question from the gentleman from Illinois. This is Janet Arno from Indiana. You very uniquely among those states with syphilis have seen apparently a big drop. So in the MMWR, it lists you as having over 400 cases last year and in the 200s this year for primary, secondary. What do you think made the difference?
I think that might be some reporting issues. And also, I think with our early cases of syphilis, they really haven't dropped that much. So maybe by the time we get a lot of cases, a lot of times they've been diagnosed by private providers, people delaying care. I mean, we're seeing similar to what you're seeing in Indiana. We're seeing more cases in young African MSM, not only syphilis but HIV.
Please mute your phones if you're not speaking.
I think somebody already did.
I think they put us on hold or something.
So they're not going to hear that message.
Yeah, unfortunately.
I had a quick, this is Michael Samuel in California. I had a quick question for the folks in Oklahoma. It's not really an area I'm involved with, but it sounds like a really creative and effective campaign in terms of the Syphilis Sucks. I'm wondering if there's any thoughts regarding misinterpretation about that being an overemphasis on oral transmission, or whether it's just, you know, it's cute, it's going to get people's attention, and that's really not a concern.
Well, we really hadn't been too really concerned about that. I mean, it's definitely an attention getter, and I wish you could see the materials so that you could kind of decide for yourself.
We also utilized a couple of other pictures and things as well, and other posters that weren't specifically the Syphilis Sucks but were related to help with that, and then just the educational outreach that we did partnered with it, I think helped alleviate some of that. But it was very effective in initiating a conversation, and that was really impactful, I think, that to help people listen to us and talk with us.
Thanks.
Who else would like to comment on anything they've seen, any changes or populations they've seen change on the ground?
Hi, this is Juan with Portland, Oregon. We are pretty much like South Dakota. 5 years ago, we were seeing 12 early syphilis cases a year. This year, year to date, we're hitting about 135. So it's been kind of crazy for us. We've stayed on top of doing online partner notification, but I really think what saved us a lot is we're really doing a lot of texting clients for initial partner notification, and it's worked really, really well. So I would highly recommend that programs consider that. We're using Google Voice as our texting program, and it's, we have a 60% response rate for Google Voice. We'll call someone, they don't answer, we'll text them, 60% will respond to the text, and it works really well.
Excuse me, who was that was speaking?
This is Juan with Portland, Oregon.
Okay. And do you have like set text content that you use?
Exactly. We've been online doing online partner notification since 2009, so we just mimic that same procedure, and we have the same three canned messages that you use for online partner notification. We use them for texting, and of course there's a limit to how many characters you can have, but it fits the client's name, your name, and the canned message. And you never ever share protected health information, but the whole goal is to get the client to call you so you can have the conversation you need to have, and it works really well.
Yeah, Juan, thanks for sharing that, because certainly research lately has said that there's a different type of urgency to text messages as opposed to a phone message or email. And when people get a text message, which is probably why people have crashes when they're on the road driving, they have an urgency to respond to that. And I think 60% response rate is pretty good based on, the information that you're sending.
Correct, and we've been doing it since December 2010.
Great. Anyone else? Want to talk about any interventions or prevention messages or methods that they're utilizing since syphilis has been on the uptick?
This is Bernard in South Carolina. Being a part of the South, syphilis has actually decreased a little bit the first 5 months as we were completing our IPR in South Carolina, but the most impacted population is African Americans across the board with the STDs, and in particular with syphilis and syphilis HIV co-infection, is young African American MSMs or young African Americans. We did something a little bit different with, we get syphilis elimination funding also, but we did something a little bit different with part of that funding the last year and a half or so. We identified 4 community-based organizations which have a entree to the MSM population, the African American MSM population, in strategic areas of the state and provided them some contractual funds and an agreement to test 900 young African Americans, and a certain percentage of them had to be, we wanted to be MSMs, to identify, well, to screen more MSMs and African Americans and to identify more cases. So far, that has been bearing fruit because of other issues that are around cultural competence, cultural sensitivity, and those kinds of things. A lot of the African American MSM population has not been coming into our government clinics, they call them, county health department sites, to be evaluated, simply because they felt they would not be treated as they would have wanted to be treated. So they go to community-based organizations. Some of these organizations also have the capacity to have medical staff on board that provide evaluations and treatments, and then they're referred to the county health department's DIS for partner services. In one or two areas, the DIS actually meets the person at the community-based organization's office and almost blends in as a part of the staff to do partner services. And that's worked really well, servicing the population in greater numbers in their environment or in environments they're comfortable in, and they've been more cooperative in providing information and details about partners, venues, events that are happening, house balls, raves, parties, hotel parties and stuff, where, you know, we've asked them to take condoms, and sometimes we've asked to come along and provide literature and things like that. Not that we ever wanted to go do testing at an event itself, because that's not why folk come to be tested. They come for something else, but we'll plant the seed. And usually they go back to the community-based organization and get tested. And then something that I don't have a real good taste for is they provide incentives to people to get tested sometimes.
Great. Thanks, Bernard. Other thoughts, comments, questions? Jan, I did want to come back to you, something that you snuck in there that sort of slid by. I think that was excellent foresight, and wanted to really tap in a little bit more about putting monies ahead of time into a media contract so that when the time came, you could quickly develop a campaign. What kind of, without, you don't have to necessarily give us a dollar amount, but when you were putting money, budgeting for that, what were you thinking, like a percentage of your funding for that?
What we have is our communications department has a contract for the entire agency, and I believe the contract's with Visual Image. And they allow each department to decide for themselves what they want to put in. And so it happened that we had, I want to say that it was $10,000 was all. But we went ahead and let them know that we wanted to add $10,000 of our state dollars. They were state dollars that were allotted to our program that could be used in any way we chose to use them. And so we went ahead when the contract was renewed and put in $10,000, not knowing how we would spend it, but knowing that generally there's some sort of an opportunity before the year's over to spend it. And so, $10,000 isn't that much, but it accomplished what we needed it to.
That's great. Thank you. I keep seeing people's speaking buttons lighting up. So if you want to say something, feel free to jump right in. Now all of a sudden they all went off. Okay. All right. Well,
this is Sydney Minnerly from Texas, and a brief update is that we are currently seeing a large increase in our metropolitan areas. We call them the Big Five in Houston, Dallas, Fort Worth, Austin, and San Antonio, and predominantly in the MSM community, as well as a pretty high number of comorbidity with 900 and 901 status. So we're kind of mirroring what everybody else is reporting. This was following a 25% decrease and another 12% decrease in the following in 2010, 2011. So we're pretty concerned because the increases are about 45% in primary and secondary.
Great. Well, thank you for sharing. Thank you. That was good information. And I really think this was really good to really highlight the excellent use that not just Oklahoma, but it seems like quite a few of you that have spoken have talked about excellent use of resources as far as your DIS are concerned. Certainly those who have interventions and things going on the ground, recruitment of partners, and just the ability to quickly put together things, whether it be some kind of intervention, whether it be a media campaign or what have you. I think it really highlights the good work that's going on out there in the field. And many times we don't have an opportunity to hear about this stuff unless we're at the annual meeting or some other type of venue. So really thank you for participating and sharing this information on today's call.
Dana, one final thing I'd like to say regarding conversations and providing information across jurisdictional lines. Everybody does that within their state, but oftentimes we forget that neighboring states see a lot of traffic of the citizenry of your state and vice versa. So in South Carolina, we've not done it yet this year, but in the past we've had opportunities to have a tri-state meeting with North Carolina and Georgia around morbidity trends and provider issues, and a whole host of things, even laws applicable to the different states and issues that we have, and best practices in our local areas or in our home state that could be borrowed or used in the other states and stuff. And certainly a lot of clients in some areas have a tendency to cross state lines for care. And oftentimes they're missed out on partner services, or they're partners that they leave behind in a home state if they go somewhere else and get tested and never become aware, because initially they're probably perceived as marginal people that just aren't initiated across state lines. Or some states have hurdles where unless you have really tight information on somebody, they're not even going to accept it, to do a record search or initiate it. So just talking through that with management and with DIS across state jurisdictional lines is an important thing as well.
Absolutely. Thanks, Bernard. All right. Anyone else? Well, thank you so much for participating. Thanks to Jan Fox and her team in Oklahoma for leading the discussion.
Thank you.
Everybody, thanks for participating. We will send out an evaluation survey of this call. And if you have any thoughts for additional calls, please let me know. Thanks. Have a great afternoon.
Thanks. Bye, Dana.
Thanks.
Bye-bye.
Thank you. Sorry if I was pausing.
Thank you. Please stand by.